I'm Janet Spake, and I'm director of the Hartford Center for Geriatric Nursing Excellence, located in the College of Nursing. And we're co-sponsoring this along with the College of Nursing and Center on Aging to bring our Ida Beam scholar here for this week. And we've really taken advantage of all of her time to talk with a number of groups, and really pleased to be able to, this is the last session, and we're really pleased to be able to have it here and to welcome you folks here. I want to talk a little bit about Dr. Beverly. She's the director of the John A. Hartford Center in Little Rock, Arkansas, at the can't ever get this right.
University of Arkansas for Medical Sciences.
University of Arkansas for Medical Science. And she's been the director there since 2001 of the Hartford Center. She also is the director of the Arkansas Aging Initiative, and that's that'll be the focus of her presentation today. And this Arkansas Aging Initiative was recognized as a very innovative model of care, both for the kind of services that are provided, but in terms of the interprofessional work and the educational work that's done. And her work was recognized at the American Academy of Nursing by awarding her the Edge Runner Award, which is a national award for innovative models of care. So I'm going to end her introduction there and let you hear from Dr. Beverly. So.
Thank you. Thank you, Janet. And I want everybody to know that, yes, I am from Arkansas. I came up here north to get cool. And I'm going home tomorrow, and I know y'all are going to be cool, but I'm going back to hot Arkansas. So anyway, that first goal did not quite materialize. I'm going to talk about our topic today within the context of the Arkansas Aging Initiative, because it's within that initiative that we've been able to really be innovative and to test and develop some solutions for our older adult population. We are very much like Iowa in terms of percent of our population who are 65 and older, and very much expected to continue in that, increasing that number. I think Iowa is 16%, the national is 13%, Arkansas is close to 15%. So we are both rural states, and we are both farm states. And I think the difference in some shape, form, or fashion is Arkansas is home to Walmart and Tyson and J.B. Hunt Trucking Company. So we have some fairly large businesses that are located in northwest Arkansas, which makes our state really skewed, because the eastern border of our state is Delta and on the Mississippi River. And as I say to a lot of people, what we know is that those individuals who live in the Delta have a 10-year less life expectancy than those who live in northwest Arkansas. So that really points out the difference between education. So goes education, so goes health, so goes economics. So with that caveat, the Arkansas Aging Initiative is a program of the Donald W. Reynolds Institute on Aging. We have been very fortunate to have the Donald W. Reynolds Foundation located in Las Vegas, who, for the most part, only funds projects in Nevada, Oklahoma, and Arkansas. We have received over $80 million from them over years, and that level of giving has really enabled us to do a lot of activities. You go backwards on here. We're really looking at the three aims that everybody in the country is looking at: better quality, better health, lower cost. And I think that we as a country, I'm very excited about the healthcare reform that has really brought about our ability or our opportunity to look at these three areas. We have focused on trying to improve healthcare outcomes. We have and been studying and continue to study workforce as what do we need to have in place to take care of older adults, and community capacity building. In Arkansas in 2001, actually it started in 2000, our then Governor Huckabee, who has been to Iowa a couple times, said that he wanted to dedicate all of Arkansas' share of the master tobacco settlement to health. We were one of 46 states to receive tobacco settlement dollars, and he tried to get that through the legislature, and of course the Senate okayed it, the House did not, and so he took it to a referendum of the people of the state of Arkansas, and we voted 67% to dedicate these dollars to health. And so it became an initiated act. And so by law, the Arkansas Aging Initiative is to establish health care programs around the state, to offer interdisciplinary education. It is to have a focus on healthcare professionals to better equip them, because most of the healthcare professionals practicing now in the state of Arkansas have not had geriatrics or gerontology in their curriculum, and so we want that current workforce to increase their knowledge in that area. And I am proud to say that now medicine, nursing, and pharmacy all focus on, and then they do have a mandatory course in geriatrics in each of those programs. So we're going to begin to see a changing workforce based on that. We also, as a part of the Act, are to provide access to dependable health care, education, resource, and support programs for that part of the population. And we were to start off with a needs assessment. We have 9 centers on aging now. We started off with 7, and we did conduct a community needs assessment in each of the regions in which we provided care. Now, it was not, I'll be honest, it was not real sophisticated because we had a very short period of time, and we did a search trying to find a needs assessment that could be readily used with an older adult population and families and organizations. And at the time, which was about in 2000, 2001, we could not find one that could be readily used. So there was one that was out there that was going to take I forgot how many pages it was, and it was going to take hours upon hours, and it just wasn't realistic. But we did a needs assessment everywhere. And one of the things that we found out in that needs assessment, and we really need to do it again, is that 55% of the participants reported that they leave their region to get health care elsewhere. And so we thought, well, with interdisciplinary geriatric health care, has that made a difference, and have more people decided to stay in their region? So there are 7 programs that are funded by Arkansas' share of the Master Tobacco Settlement. Our program, the Arkansas Aging Initiative, receives $1.5 to $2 million annually, and it's a 6-year commitment. Arkansas receives about $56 million annually, anywhere from about 48 to 56 million. It varies every year. The methodology that is used is always not real clear to everyone. Supposedly it's based on what people pay for tobacco products, so we always say go buy the products but don't use them so that we would have more money, but I'm not real sure what affects that. That money has enabled us to raise over $8 million, and we really have added to that $8 million because one of our current projects was a total of $11 million. So I know that that $8 million is a conservative estimate. We did start out, we were only going to do 7 centers, but we have 9 because 2 other entities came forth and wanted centers, and I'll talk about that in a minute. It is a partnership model, and in Arkansas we have in place a very good area health education center. We also have the Arkansas Geriatric Education Center, which through our partnership with them, they do all the geriatric education for healthcare professionals. That's what they're funded to do, and they work very closely with us on that particular entity. We partner with local regional hospitals. The clinic that we run has to be within 35 miles of its parent institution, so UAMS could never run those clinics. We also have at the table with us the Area Agency on Aging as a part of trying to maximize between the two of us the precious dollars that come into the state and not duplicate what each other is doing. We've had engagement by community leaders and other members in the community so that what we have developed is based on community needs as well as the model of care. And then local colleges and universities. We have faculty who have served on our leadership committee, and we have students who are very much a part of it. So this was our overarching goal, to develop centers on aging using an interdisciplinary clinical care approach and innovative education programs, and also to influence health policy. So our vision is to be a leader in improving health of rural America. That would fit really well between Iowa and Arkansas. It is also to improve the health of older Arkansans, and I mentioned that through education and geriatric clinical care, and then health policy. This is a map of the state of Arkansas that shows our 9 regional centers on aging and the counties that each one serves. This Brown County, you see it's one county, that was one of our newest sites that came up about 5 years ago. The Sella family from St. Louis owns the racetrack, horse racetrack in Hot Springs, and they wanted to add to that video games of skill. And so their carrot to the community, because the community had to vote on it, was that if you vote this in, we will create $1 million foundation, and $500,000 will go to create a center on aging, and $500,000 to students in Hot Springs that will be going to college and pay for their college. And so by a vote of 8 votes, it was passed. And so we have started the Center on Aging. In addition to that, they also have committed 0.5% of the proceeds to each of the 2 programs in perpetuity. So they are supporting the Center on Aging in Hot Springs. And then in North Central Arkansas, that is our newest one that came up this year, and the Baxter Regional Hospital was so impressed with Centers on Aging, they wanted to be a part of the Arkansas Aging Initiative. They are completely funding both the education and clinical component and have created that Center on Aging. So the 2 components in every Center on Aging is interprofessional geriatric teams and that is a geriatrician, advanced practice nurse, and social worker at a minimum. Depending on availability and funding by the hospital, we have other disciplines, sometimes part-time, full-time, that would include pharmacy and nutrition most commonly. Two of our centers have neuropsychologists, so that the neuropsychologists do memory testing and have created a memory care evaluation component. Our education targets healthcare professionals, newly established now paraprofessionals, students of the healthcare and social services discipline, older adults, their families, and the community at large. Our clinical services are provided out of a hospital-based outpatient clinic. And that is a clinic owned and operated by the regional hospital, local hospital. They collaborate with the Center on Aging. It's a part of the center, and that education and clinical care together develop the synergy that goes along with that. We do have the interdisciplinary team approach. It is Medicare reimbursed, but it's different than a private clinic in that there is a facility fee and a pro fee that these hospital-based clinics can secure. And it is also different in that, let's see what I was going to say. Let's see, Medicare. Oh, I'll have to come back to that other thought I had that went away. Our primary focus is primary care, but we focus on functional independence, prevention, and high-risk aging. At first, when we started these clinics, physicians in the community, we were anxious about whether or not they would think that we are encroaching on their patients. But what we're finding is that many of these practices have limited or even have closed their doors to Medicare patients. And so that competition with them has never arisen. A couple of our clinics started off as consultation clinics, not primary care, and found out that that was not the way to go. And so all of them are providing primary care. All of them do provide some consultation services. And when we have individuals, especially those high-risk aging, when the care is so complex and takes up so much time, the primary care physician that they had been seeing are very happy to share trying to figure out how best to care for these individuals. Our clinic is these type clinics, we allow 1 hour for new patients and 30 minutes for return. So you think about what goes on in a primary care practice, usually is 12 to 15 minutes, if that long. And with older adults, this has proven to be absolutely the right way to go and appealing to the older adults and their families so that they have time to really talk about some of the challenges, and especially as they become more high risk. We also, some of our clinics provide primary care in nursing home, assisted living, and in-home care. There's a nice revenue stream for in-home care, commonly referred as house calls, and that's different than traditional home health. And the advanced practice nurse and the physician both provide primary care, and they each one does it a little bit differently in terms of how much time one devotes to whatever. I find that most of the time our advanced practice nurses are found more in nursing homes and doing in-home care than the physician is, because it's more cost-effective and the needs meet the what the advanced practice nurse is educated and can do. Our clinic visits, you can see through 2008 through 2012, and these are important. These are visits, and they reflect somewhere around 16,000 patients total. And in Arkansas, about 435,000 individuals are 65 and older. So when you look at the number and you think 16,000, these clinics don't really get very far in terms of interdisciplinary specialty care. So that really brings on the importance of educating all healthcare professionals about geriatrics because, for instance, hospitalists, on any given day in a hospital, 60, 70, 80% of the individuals there are 65 and older. And nursing homes, of course, the clear majority are 65 and older, as well as assisted living and then the in-home care. So while we don't have enough geriatricians, advanced practice nurses to take care of 435,000, we do have individuals that if we increase their knowledge about geriatrics, will be able to provide better geriatric health care. We are also this year have implemented some new services in some of the centers, and these are new codes that Medicare has provided transitional care, in particular in chronic disease management. This is the slide that I'm most excited about. It shows that 98% of Arkansans are within 60 miles of interdisciplinary geriatric health care. And, you know, you say, well, will somebody drive 60 miles to get this care? I tell you, when people are high risk, having major problems, what do? Families are at their wits' end. They will drive, might only be once or twice, but they will drive to get the kind of help that they can get from geriatric specialists. So we have individuals all over the state that will drive. Now, do I think that the majority ought to? No, because we don't want those people 65 and older, for the most part, on the road. You know, we want them to stay at home as much as possible or close to their home. And, but that is, at least we have increased that specialty care to our citizens. Our education, I mentioned earlier who we target, and some of the examples are information about the aging process, common diseases of older adults, of course, tobacco cessation. Even with older adults, we know that it is a good thing, and it does have positive results if they do quit smoking. One of the things that we do that I think is very important, and that is about community education. A lot, if not most, of community education is not based on the evidence, and it is provided by individuals who are, quote, known experts in the field or have been taking care of patients for a long time with this kind of healthcare problem. But it's not evidence-based, and it doesn't bring in what does the science say today. And so twice a year, our education directors identify 2 areas of need for the state, and with that, we'll do a literature search, we'll look at what is the state of the science, and we'll then provide programs. And for FY12, immunizations and caregiving were our topics. They gave 80 programs to the community, and then the Geriatric Education Center gave 16 programs to professionals. So we make sure that those 2, the healthcare professional education and the community education, dovetail with each other so that we have a better informed consumer base as well as healthcare professionals. So we see Arkansas, and Brian and I had an interesting conversation today. We did not start this as a research project. It started because the state came to us and said, we want you to create a program for older adults, and we want it to be out in the state. We don't want it to be located in Little Rock, Arkansas, because you already have the Reynolds Institute there. And it's like you really get into this conundrum. You want to do it from a research base, but then when it comes, right now, other than to see is out there in the literature and what can best inform the way that we are doing this at this point. And so that's how we have started. But what we have what we have in place now is an infrastructure that can be used for research from a multi-site standpoint or just one site, or and test innovations and solutions that are facing the country, and how do we prepare for that. With Arkansas being ahead of the national average, then in, say, 5-10 years, the national average is going to look like we are right now. So we have an opportunity to really test some model development or practice across the board or education. And so we view the state as our laboratory, and we welcome anyone to help us as we look at research needs and what we need to do. Another major part that I think needs to happen with any development or innovation is to engage individuals in the process. We have over 700 partnerships total, and those 700 partnerships include civic organizations, hospitals, universities, Area Agency on Aging. They are partnerships that are critical so that we maximize the use of the dollars that we have and put our heads together and collectively understand and develop the best solutions possible. We are very much a proponent of community engagement because we want to build capacity in the community so that the community can be and should be much a part of solving the problems for the community. Every one of our centers are decentralized, or the Arkansas Aging Initiative is decentralized. We want each of the centers to be addressing the needs of the people in their region and to be involving individuals in that. We don't want Little Rock, Arkansas to be telling everybody in the state how they ought to operate. And I think if you were to ask our directors and education directors today, that has been the way that we have moved forward. And our retention rate of our directors and education directors is about 95%. And, you know, we started with this in 1999 with our first center and have moved forward. We also have national partnerships. I just mentioned a couple right there. So I mentioned earlier, looking at the 3 aims of better quality, better health, and lower cost. Some of the quality of care that we are focusing on is that we have experts in geriatric knowledge, whether it's medicine, nursing, social work. It is those individuals that are providing the one-on-one care with individuals or families or the community, and so we want to make sure that those that the hospital actually hires the interdisciplinary team. So we work with the hospital in the process of acquiring individuals to make sure they have the background in geriatrics that they need to have. Let's see. The impact of the Arkansas Aging Initiative. And we have been conducting some studies, and we are not as prolific as I would hope that we would be. But I can tell you from experience, to get a statewide system up and going, to get 9 centers now going, to maintain that these centers are providing the expert care, but also are credible in what they do, and that they are staying on target with what it is that the law says for us to do. We have looked at kind of 4 different areas, and that is to measure access and quality for seniors served through the regional centers, and then to compare before and after implementation of the Arkansas Aging Initiative services, and then to compare those seniors served by centers versus other sources. And other sources, in our case, has been freestanding clinics, and then to take a look at some cost implication. So if we were to look at those served through regional centers, we look at community programs, and there are several of the programs that we have conducted that we have done primarily pre and post follow-up. And in doing that type of evaluation and research, we have found that we do make a difference. That level of knowledge, for instance, before and after is different and has been different in each of the ones that we've done. Now then, the question is, you would hope it was different. You hope that they would be listening to you as, part of the education, but do they take it and change their behavior? And that we have not been able to track as much as we would like to, but that is absolutely critical, not only for the consumers, but also for healthcare professionals. You can provide education all you want to, but are they going to change the way that they practice based on that? And the Geriatric Education Center has tried to get at that, and their findings, even though it was a very small group that of participants that provided the information requested, they did say that they changed their behavior. I can also give you an instance where in Arkansas, in long-term care, we had about 24% use of restraints in the country, with the country being about 3%. And over the next 8 years, the Arkansas Aging Initiative and our Hartford Center in particular worked with a number of groups in the state, and we are now down to right at 3%, with the national average being under 2%. So that's an example of, yes, there was a behavior change there. What we found in that process too, that there were some schools of nursing teaching about the use of restraints and how to use them and so forth. So we had to try to impact, the education as well. So it's trying to continue to see that, are you doing education? Is it making a difference? And what difference is it making? And if not, what do you need to change? We also, in a comparison before and after, we ask individuals in 2 of our sites, and this has been a while back, about 8 years ago, we ask them to tell us about their satisfaction of the health care they received prior to coming and enrolling in our Center on Aging. So on their first visit, that was given to them before they even went to see the healthcare professional. And then in 12 to 18 months, we went back to those individuals and asked them what was their satisfaction of the way they were receiving care now. And what we found was, in every question that we asked, there was, at both sites, there was a statistical significant increase in their satisfaction with the level, their satisfaction of the care they were receiving through our clinic. And so we have not broadened that to all of our sites now to really test that in a broader way, but that was good information that we got at that point. Let's see. This kind of gives you some of the detail and how the majority clearly reported receiving better care from the team and so forth. Lower cost. this has been interesting to us, but geriatricians in 3 of our sites, as well as at the University of Arkansas for Medical Science Clinic, their practice in the hospital, when compared to peers, and peers being those in primary care, internist, and family practice, the geriatricians had the lower length of stay of any of the primary care physicians and the lower cost per case. And that, we feel, is quite significant in terms of hospitals or in terms of Medicare really paying attention. And it's just amazing to me when we talk about geriatricians and the results here that there are fewer individuals becoming geriatricians, because if you become a geriatrician, you're going to make less than if you were family practice or internist without going on to be a geriatrician. But yet, the demographics in this country are compelling to why we need more geriatricians and why we need more advanced practice nurses with geriatric background in really all disciplines, pharmacy and social work in particular. And then this was a study that compared quality by what was provided by the Arkansas Aging Initiative centers versus other sources. And this was a secondary data analysis, and we partnered with the College of Public Health to do this study. And they looked at the Arkansas Hospital Data System and Medicare claims data, and it was a very good study. Dr. John Wayne, Dr. Glenn Mays did the study. Dr. Wayne presented at APHA last year, and he has now retired, so we're having trouble getting hold of him to move this forward in publication. But they also had questionnaires of medical directors of senior clinics as a part of their study. It was retrospective. They looked at geographic areas served by the Arkansas Aging Initiative. They looked at and the comparison was between the geriatricians who were, and they were identified by hospital as well as the geographic area. And they did look at before and after the AAI intervention. And they did a multivariate risk adjustment to control for patient differences. See, I've already mentioned that. And the whole study was to look at potentially avoidable hospital admissions. And they, I'll get to it later, but they used the Agency for Healthcare Research and Quality methodology of looking at this. And so they found a significant reduction in hospital admissions in our AAI physician hospitals. That means where the physician was practicing in the hospital or had that relationship with the hospital after the establishment of the center compared to other hospitals in the service area. And these are the areas that they looked at. It was 5 of our centers on aging. And what they found was, and these are the areas in which these centers had anywhere from 1 to 4 avoidable hospitalizations. And, a hospital CEO might not want to see this because they want hospital admissions, because hospitals like Medicare, even though some may say they don't, they really do. And yet, this is a potential cost saving to society in terms of, let me show you the other one, in terms of a number of areas, healthcare, that we were happy to report from the difference from our Arkansas Aging Initiative. So this gives us pause to think, well, if this happened, and we did it without saying, I'm going to deliberately work with congestive heart failure. I mean, and it happened because of the specialty geriatric care the team we had in place, the kind of practice that was being in place. So now we're at a point, well, we can tweak some of these programs. How do you bring in other programs such as chronic disease self-management that will indeed impact even more what it is that we can do? An area that we've been working on in a couple of our areas, for instance, is with nursing homes. And we are now, with the practice from advanced practice nurses and the medical director geriatrician, have been focusing on treating residents and keeping them in the facility and not sending them to the ER and to the hospital. And we've done that through education of the staff and through education of the family about we can do most of what your loved one needs right here. And that means then that that individual won't be transferred to an ER or hospital and can stay in their own environment, which is much less intrusive on that individual, and results are better. So this kind of information does and is helping to direct us in terms of what we're doing. So I'd kind of like to stop here and for the next however many minutes that we have, talk about some of your observations from something like this, some of the things that you think we need to be focusing on in the area of gerontology, geriatrics, and some of the solutions that we need to come to grips with. The area of chronic care self-management is an area we have in our center, or in our whole initiative. We have 22 master trained individuals from Stanford Chronic Disease Self-Management. And Stanford has developed very good two things. One is a general program, 6 weeks, on how do you live with chronic disease, and the second is on diabetes self-management. But we've got all these other areas, congestive heart failure, you know, we can name one right after another. So we really need to be focusing on how do we, what do we need to have in place, where can we get that kind of education. And one of the things about the Stanford model, it's a 6-week program. And I can tell you, to get completers out of a 6-week program has not been easy. People will sign up at the beginning, be excited about it. Then when they realize that it's, I think, 4 hours, 6 hours every week for 6 weeks, we lose people because they don't want to make that kind of commitment to it. But yet, chronic illness costs this country right now billions of dollars, and I'm talking about 5 or 6 billion, with about in 2017-18, it's projected over 900 and something $billion. So we talk about healthcare costs escalating, chronic care costs are escalating, and we need to find ways that we can keep that cost down, but we do it through individuals managing. And I've said it in several instances, so for those who have been in several of the meetings, but ultimately it's our own responsibility. People know you can provide the best education. You think that, okay, here's the education, you've got it, you'll do great. Well, no, individuals go home and fall back into previous behavior, and what will motivate somebody to use that information or not. We have to look at some of our devices, such as alcoholism, substance abuse, and I think about the diabetic that we really spend a lot of time trying to help, and they go home, the next thing you know, in 2 weeks they're back in, and they haven't done either the insulin right or whatever medication they're on, and so forth. So it's that disconnect, and for us not to be paternalistic, and I say us healthcare professionals, but to understand that how can we best help individuals make decisions that are good decisions about their own health, knowing that they will they are responsible to do that, not us.
I think the whole style of our education and how we've learned to educate needs to change, and there needs to be more focus on the motivational interviewing and how do you communicate with people to help them change their behavior. And I don't think we have enough training in that, and that's a real art. I mean, there's a real art to changing the way you communicate with people.
You know, and I'm glad you brought that up, because some of what we have found, and especially we're finding that as a country in transitional care and preventing readmissions, and what seems to be preventing some of those readmissions are just a phone call ever so often, you know, whether it's once a week or more often than that, and you start finding out, we're not the point where we need to be, and, you know, bring people in. Because just because they made it 30 days and not readmitted doesn't mean that they are monitoring their congestive heart failure, you know, for the rest of their life. And I think you're absolutely right. It's that motivation or behavior change. We know that we have provided, quote, good education, evidence-based education, but do healthcare professionals even change their behavior in the way they take care of older adults? And we have found that no, and pharmacy, polypharmacy is a big area, you know, so you're right on.
Well, and kind of continuing on that, it's not even really embedded in whose responsibility is it to do that. You know, because certain nurses have not been really socialized to do that. And I don't know about pharmacists, I don't know who has been socialized to do it, but, you know, the idea of like nurse care managers and other care managers who do that gentle health coaching follow-up to keep people on target is needed. And it just doesn't really exist system-wide.
It is interesting to see. I mean, the follow-up call, I think, is critical, and a lot of, I think, emergency departments are starting to do that and seeing lower readmission rates. So that's one piece of it. But I know here at Iowa, the pharmacy school is training their students in motivational interviewing techniques, but I think that needs to be pervasive. You know, something we're lacking, I think, at Iowa, as far as in the nursing college, something that could be added.
Well, I think across disciplines, because you know, it's no one discipline has the market on all the care that someone needs, and I think we need to really take a look at it in the broadest context and what do we need to do to be the most successful. So I think, good point. Any other?
So, first, thanks so much for enlightening us on the story of the Arkansas AG initiative. Right? It's truly fascinating. Since we're sitting in a college of public health building and we think about health policy a little bit, I wonder if you could comment on what the scalability issues might be.
The scale of what?
Scalability issues, taking this outside of Arkansas. And two things come to mind. You've benefited marvelously from the Reynolds Foundation and the Tobacco Act. Okay? So you got a boatload, I'm supposed to watch my range, you got a boatload of money to be able to support this and, you know, widespread approval. At the same, so, you know, would it work in other states? And the other thing that I have a little like to reflect on is, in addition to the support issues about scalability, is there something terribly unique about Arkansas, perhaps, in terms of the stage of the quality of care for older adults to start with that led to such rapid improvement levels that might not be found elsewhere?
Arkansas usually ranks at the bottom in terms of health outcomes, and I am proud to say that this year in the report card we're 46 and in terms of older adults. So, you know, and so we did make that. In terms of scalability, and we have spent quite a bit of time thinking about this, and I'm going to answer it in a couple of ways. First of all, we are replicating this in Oklahoma. The Reynolds Foundation, though, is paying for the replication. You know, so that is a good thing. And when the Reynolds Foundation goes out of business over the next few years, then, you know, they're worried about what's going to happen, primarily from the education standpoint. Now, the thing that we have found, and that to me is where we're going to have to do better about engaging our hospital partners, is that in this type of clinic, when we first started, we didn't think they made money. And so we always said and tied it to the downstream revenue, which means increased hospitalizations, ER visits, PT, OT, X-ray, whatever. And yet, over time, what we find is these clinics do make money. And not only do they make money, we have conducted research that shows for every dollar that is generated in the clinic, $22 is generated in downstream revenue for the hospital. We had a clinic last year that made $1.4 million. So, you know, it's like, you have some money coming in here. And so if we were to engage hospitals outside of Arkansas that say their state does not have the tobacco settlement, what is a way to pay for the education component except through that downstream revenue? The other thing is that, say, transitions or chronic disease management, as Medicare is developing codes that will pay X number of dollars, then how can we bring some of the education into that clinic so then that component or components of education will do that, you know, we'll be able to do that. And so I think that continues to be a big struggle because education does not generate money as such, but yet it is an important part. So then we start looking at how can we do education differently using telecommunication and so forth. And all of our centers now have telehealth equipment so that we can at least do telehealth, and we are doing some distance education kinds of activities so that it may be that rather than have a director of education for each center, we only have a few education directors and they're responsible for the whole state, but we use a different strategy for getting that education out there. But I have to say that clearly the hospitals that I've talked to thus far understand how important this is to them. And I say that, you know, a year and a half ago when everybody was writing for an innovations grant through CMS, and I was working with New York, and NYU was working on one and wanted to replicate the Arkansas Aging Initiative, and we were going to target 2 hospitals. And so as we were writing it, I got to go to New York City, and the 2 sites, the 2 hospitals, one was in Cooperstown, which is 4 hours north of New York City, and one was in Brooklyn. And we visited both hospitals, and within 2 hours, both hospitals said, yes, we will do this. We will be happy to set and hire the team. And, you know, so it's like they acted just the way the 7 hospitals that we targeted in Arkansas did. So I think there's something to be said for us exploring more with hospitals that if they did this, and if the level of income is what we are seeing now, then how they might assume more responsibility for the education component to keep that going. Because I think sustainability is going to be extremely important, especially, I mean, we've got funding for 26 years. I won't be here at the end of 26 years, at least in this position, but I would want this kind of program to continue. So it is a very challenging point, but yet I think that you know, we need to be working on it. I know Oklahoma is very anxious about it. So
if I could just follow up, because I thought it was very creative of you to say the focus on the downstream to the hospitals to support this. And it surprised me also because I think your second slide talks about the triumvirate for future in healthcare delivery. And one of those is reducing care costs. So Isn't that sort of like a little almost oxymoron?
It kind of is. I mean, I don't deny that, but on the other hand, are we really going to be seeing clinics like this as being extremely important, keeping people out of the more costly hospital and even out of nursing homes and out of, and I'm going to say assisted living, or at least that component of assisted living that has gotten, oh yeah, we can provide this if you pay this, and they keep adding on, and yet it's like these people don't need to be in assisted living, they need to be, you know, elsewhere where they get the 24/7 care. And so I think that as the system goes through the change, what implication is that going to have for these clinics or for the hospital? I mean, you're absolutely right. And I don't know, I don't have a crystal ball for that other than to keep our eye on what's the latest thing that came down. Just like we talked about the transitional code that came out in January. Well, you know, that's a piece that we can put in place that wasn't there before. So, you know, trying to influence policy through things like that and what difference it's making. But I do believe that our education needs to be done a little bit differently, and I do believe that our education, what we can move into the clinic that is reimbursed rather than being out there and paying for something that is reimbursable, at least right now through the clinic, we need to keep investigating and doing surveillance about that. I don't have a clear, good answer, but it's like, you know, we just have to keep trying, and we have to keep, how can we influence policy, and how can we, you're right, the very beginning, better, lower cost, and we've got to talk about that, because obviously these hospital-based outpatient clinics, you know, they haven't really changed in the way they're reimbursed since, what was it, 01, when the prospective payment system came in. It was fee-for-service. Well, I still see it a lot as fee-for-service right now. And how is managed care going to affect that, or ACOs, or, you know, other entities? Well, thank y'all very much for coming this afternoon, and I've really enjoyed being here in Iowa, and look forward to another trip, I hope.